3 minutes. I think we'll start now. All right. So good evening, everyone, and thanks for making time to attend out of hours to this talk. So we're going to talk about a clinical scenario. The first hour, we'll be discussing a few clinical details about the patient, a little bit about history taking and examination, and a little bit about investigations. We won't be going into very much depth, but I hope you will get an idea about what areas you need to focus on when you start to read about this condition and when you manage patients. Just to get a feel, can I get an idea with a show of hands, how many fourth year students are here? Hands up, just raise your hands if you're from the fourth year. Right, so around 40 from fourth year. Right, okay, hands down, please, thanks. Final year. From the final year, okay. Third years. Any third years? Right, okay, so we have a few third years also, right? So a couple of words on the general progression that we expect during the 3 years that you are in clinicals, from your MSGOP through your long clinical rotations, to your prof unit. During the first year, we would probably expect you to get training in what's called information gathering. That means eliciting signs and symptoms during your examination, right? Taking a complete safe history and knowing the structure of history and how to take it. You might not always be able to interpret the information that you gather. You won't know probably why this patient has a dullness when you percuss, or why this lump moves up and down, or something like that. But you will know how to demonstrate that sign, and you will know how to elicit that symptom by asking a history. You might not be able to interpret why someone has difficulty in swallowing or rectal bleeding, but you will ask all the necessary questions, right? And so slowly during that year, you will get used to interpreting those signs, right? And interpreting those symptoms. As you go into your fourth year, it's pretty much taken for granted that you can elicit the signs and symptoms, and you can interpret those signs and symptoms also, right? That your history and examination is not just a blanket thing that you're doing according to a stencil in the book, but that you're actually thinking about this and you are gathering information and understanding what you're gathering. So during the fourth year, the new skill that you will be expected would be to also be able to interpret investigations and know what investigations are done, and also knowing the outline of the management of a condition, right? When you come to your final year, the professorial unit, that's when you would get actively involved in the management of the patient, right? So that's when you get to work like an intern. The ultimate objective of the whole program is to create a safe doctor. So during your final year, you're practicing by doing pretty much everything that an intern should be able to do to work as a safe doctor, which means that your skills in information gathering, information interpretation, right? Investigative workup, management, you should have an outline of those when you come to final year. What I mean to say is, final year is probably the worst time for you to be learning how to examine a hernia, right? It's probably the worst time for you to be learning how to examining a thyroid, things like that. Because if when you are given a case at the clinic or in the ward, if you have problems in examining a hernia, in examining a thyroid, in examining a knee joint properly, something like that, then whoever is the consultant who's supervising you will take time to correct those things. They will not just listen to all that and then discuss the management, right? That's the issue. So only if you can do a fluent history and an examination will you go into management, which means that if you spend your final year practicing just history and examination, it would probably be at the exam that for the first time you finally get to discussing management, which is a dangerous place to be in. So third years and fourth years, try not to come to final year and then start to practice information gathering and interpretation, right? You should practice the skills before you get here. If you are in prof unit at the moment and if you have stuff to catch up, then please work doubly hard because you have got your work cut out for you. Right, so that's just a couple of words on that's a broad overview that is relevant not only to today but to other clinical scenarios also. So today we are going to talk about a man, right, who has presented to our surgical clinic with a painless anterior neck swelling for 8 weeks duration, right? This is the chap. And when you ask him whether there's any other problem, he also says that he's very stressed and anxious and that he sweats a lot recently. Right. So that's the presentation. Right. Right. So what I want you to do now is to take a couple of minutes and think of this presentation. A 34-year-old with a painless anterior neck swelling, recent onset 8 weeks, and he's very stressed and anxious lately, and he sweats a lot. Now, think about this for a couple of minutes, and we need to think of what differential diagnosis you think of when you see this condition itself, right? Okay, so there can be some differential diagnosis that relate the anxiety and the neck swelling together. There might be other differential diagnosis where you will give one for the anxiety, one for the neck swelling, etc. Right. So some of you, some differential diagnosis you have will combine all these together. Some will have separate reasons for these. So these are two problems there. Right. So I want you to type in the chat what differential diagnosis you think that this man has. Some of them may be related, like I said, some of them may be unrelated. Just brainstorm, think of whatever you can and type them in the open chat so that everyone can just have a look and all of us can just see what everyone else is typing. Yeah, go ahead and just type in whatever you think. This is not an assessment, right? We are going to be talking about the MCQs later on, so just feel free and type in whatever you think. Okay, so first possibility that has come up, toxic multinodular goiter. Okay, keep typing. The more we have, the better. Good. You have dropped several responses in the chat. Keep going. Yeah. So far, we have toxic multinodular goiter, Graves' disease, thyrotoxicosis, Graves' disease, Graves, toxic multinodular, toxic solitary, Graves, toxic solitary nodule, Graves' disease, STN, that is solitary toxic nodule, Graves, solitary toxic adenoma, toxic goiter, toxic solitary nodule, Graves' disease, autoimmune thyroiditis, Graves, pheochromocytoma, thyroiditis, initial presentation, toxic multinodular goiter, unrelated, lymph node, early stage of autoimmune thyroiditis, Graves, thyroiditis, adenoma, lymphoma, Hashimoto's, pheochromocytoma, relating both toxic multinodular goiter, solitary nodule, unrelated anxiety, pheochromocytoma, swelling could be a lipoma, carotid body tumor, lymph node, thyroglosal cyst for anterior rectum, toxic multinodular goiter, Graves' disease, thyroglosal cyst, anxiety disorder, lymph node enlargement, lipoma. Good. So that was quite a kind of comprehensive discussion there. So yeah, excess thyroxine injections, says another person. Yes, good. Could be so many things, right? So we don't really know whether all of what the patient has can be unified into a single diagnosis or if they can be unrelated, right? So you can get another, this is a common problem that we have, right? So which one do we choose? Do we choose a single diagnosis that combines everything together, or do we go with different diagnosis by each of these things? So that's a question that you will often come across in your clinical practice. The answer to that is given in a book. Well, it's not a surgical book, but it's quite a useful book to learn how to think about medicine from. Does anyone know what this book is? Yeah, you can just unmute your mic and let us know if you know what book this is from. No one?
Oxford and
good, yeah, it's from the Oxford Handbook of Clinical Medicine. No, so there are some things here which are quite useful not only for medicine but for other clinical specialties also. So some of the words here are not useful. This is Latin, but basically the important thing about these two statements is this. The first statement says something like this. Try to find a single disease to explain all the symptoms rather than 2 or 3 unrelated diagnoses. So that's one thing that we should try to achieve all the time when we try for making a clinical diagnosis based on our history and examination or even investigations. We need to look for a diagnosis that unifies all the symptoms, explains all the symptoms, rather than 2 or 3 unrelated ones. The problem though is this. If that single condition is a rare condition, right, then that's not going to work. because the patient is statistically more likely to have two common diagnoses than a single rare condition. Okay, so that's why you need to think about how common each of those conditions is when you talk about it. So if you take now, yes, pheochromocytoma is a possibility. It's not common, but it's a possibility. Anxiety disorder is also a possibility. Out of the two, obviously, anxiety disorder is much more common than a pheochromocytoma. So it's more likely that the patient would have a different type of neck swelling and anxiety disorder than perhaps a different type of neck swelling and a pheochromocytoma. So that's kind of the thought process that you need to be indulging in, right? So that's one interesting thing. Another important thing that you hadn't mentioned in your chat, which you might need to think about is, now, no one had said that this could be a normal non-toxic goiter with something like a pheochromocytoma. The two things don't need to be always different, always completely unrelated. One, the anterior neck swelling could be just a goiter, not a toxic goiter, but the patient could be naturally an anxious patient, right? So that's another possibility that we need to entertain. So this is just a way of thinking about how to come to diagnosis. So summary of what I wanted to say, this is not just for this particular case, but very generally, is try to find a diagnosis that explains all the signs and symptoms, unless the diagnosis is very rare, right? And the symptoms can be explained by a combination of common diseases. A typical example in thyroid used to be, we used to get patients who had a goiter and murmurs and bounding pulses and things like that. Lots of cardiovascular signs and symptoms. A while ago, it was more common to have multinodular goiters and things like rheumatic heart disease, right, than to have toxic goiters. So people with a murmur, right, a large goiter could be to unrelated conditions if those two conditions are more common than a condition that has both a murmur and a goiter, that is a toxic goiter. So those are things that you need to think about, right, when you think about a differential diagnosis, right? So this is what we mean by interpretation. Interpretation doesn't just mean, okay, I've taken this history, I've examined this patient, and according to these and Hutchinson's clinical methods, these are the possibilities. You need to think like this and try and work out what your patient has. And you also have to show the examiner that this is your thinking process, right? Okay, so that was just a bit of an approach to how you need to think about your differential diagnosis, not just here, but in any case, right? So now we are going to move on to the second area that I want to talk about today, which is a brief structure of how to take a history in thyroid disease, right? So if you're given a short case in thyroid disease, you don't have time to take your complete history that we usually do. Your whole history and examination in a thyroid, a hernia, or a breast lump would be something like 7 minutes, right? So within that 7 minutes, you need to be able to take a full, a useful history and also examine. So you have to just target what problems you want to solve, right? So now again, let's make a list. This is regarding what areas of information you want to gather in a history if you think that this patient has thyroid disease or any patient has thyroid disease, right? One example would be, instead of saying this patient has diabetes, does this patient have hypertension, does this patient have dyslipidemia, etc. Overall, you know that you are asking all those questions because you want to assess the patient's fitness for a surgery, right? So fitness for surgery is the area that you're looking for information in. So like that, just try and brainstorm and make a list now of areas that you want to gather information on in your history. Just type them in. Okay. So first response is thyroid status. Yeah, that's good. Whether it's benign or malignant, right? Risk factors. Symptom analysis, etiology. Yeah, etiology depends on the risk factors. Features of malignancy. Complications, compressive features. Compression symptoms, duration, how long it's progressed. So no, duration and how long it's progressed is not a problem. That's not a area that we need to focus on. That's yes, that is part of the symptom and the symptom analysis. That is true. But what I want here more than that is what areas of information we want to gather. This is very different from your standard structure of the history, not history of the presenting complaint and then the symptom analysis, social history, not like that. I just want to know what problem areas you have. Right? Drugs, malignant features, complications, fitness for surgery, cosmetic concerns, compressive symptoms. Previous history. No, previous history is not a problem area, right? Problem areas here are different. Compressive symptoms and retrosternal extension. Okay. Etiology, local effects, thyroid status. Good. Emergency or not? Yeah, that's important. Occupation by itself is not really important. How much patient concern about the problem? Good. That is a problem, definitely. Whether the enlargement is diffuse, solitary, or multinodular? No, we are talking about history. Comorbidities. Okay. Again, related to fitness for surgery, usually, isn't it? Cardiovascular system status by itself? No. That's again just part of exam history, right? What we want to know is what problem do you interpret using cardiovascular system status? Metastatic features, breathing difficulty, dysphagia. Okay, we'll stop there for a moment and talk about dysphagia. This is an important area. So I think I will just take a couple of minutes to speak about dysphagia before we go on. One response was patients having dysphagia. So I just need to show you the structure of the gland to give you an idea about that response. Right. Give me half a second. I'll just load up an image. Yes, okay, I have found an image. Here we go. Yeah, hope you can see this. Right, now, like you can see here, this is the esophagus, okay? Right, so this is the esophagus. And the thyroid is the, and this is the trachea. This T-shaped thing over here is the trachea. Now, the thyroid, as you can see in this cross section, is wrapped around the trachea here. Now, if a thyroid is to cause dysphagia, it should press over here on the esophagus, right? back here, which means that what we are saying, and if the patient has no other features of infiltration, then that is a bit unlikely, because what we are saying is, okay, does anyone know what this little dot over here is? This thing, there's a little dot over there. Anyone? Between the
Recurrent laryngeal nerve.
Yeah, good. So the recurrent laryngeal nerve is just there, no? Right. So the recurrent laryngeal nerve is just there, right? The carotid sheath is just here. Okay. What we are saying by saying that a thyroid causes dysphagia is that this thyroid has avoided going into the trachea and causing stridor or difficulty in breathing, has avoided going into the recurrent laryngeal nerve and causing voice change, has avoided going into the carotid, right, and causing either a stroke or thrombosis of the internal jugular. Without doing any of that, we are saying that it has just gone through here and infiltrated the esophagus to cause dysphagia. That is extremely uncommon. Okay. So if a patient with a goiter complains of true dysphagia, difficulty in swallowing a meal, right, and if it is something that is progressive, then the first thing the patient needs is an upper GI endoscopy to exclude a cancer of the esophagus. Okay. Thyroids don't cause dysphagia. Patients sometimes do say that they feel like there's something sticking in the throat and things like that. That is not true dysphagia. It's dangerous to present dysphagia as area in the history when you're talking about thyroid. So that's an important thing to remember. Right. Okay. So it's good that you brought that up, because unless you bring up those issues, we won't be discussing them. Right. So what areas do we need to gather information on? Let's check the other responses now. Drugs patient is on, metastatic features, functional problems. Yeah, keep going. Anything else? Exclude other differentials. Good. Yeah, so good. So you are understanding the problem. We are not talking here about history of presenting complaint, duration, past medical history, things like that. We want a small set of problems to find answers to, so that we can make our short case history more efficient, right? So I think you had mentioned most of the areas there, right? Tracheal deviation, again, that is examination. Okay, that is not history. We're just talking about history here, right? So in the history, the areas that we need to focus on. Let's move to some of the areas that are important. Yes. So like someone said, one of the most important areas is the thyroid status. Now remember, when you examine a patient, the patient might give symptoms of clear-cut hyperthyroidism. I am sweating, I am anxious, right? I am losing weight, right? So there are so many conditions that cause loss of weight, no? Carcinoma of the esophagus, carcinoma of the pancreas, diabetes, all these things cause loss of weight. What is special about the loss of weight you get in hyperthyroidism? Anyone? Unmute and talk.
Associated with increased appetite?
Yes, appetite is increased, right? Not decreased. So that's the interesting thing. They are hungry and they are losing weight. Okay. Diabetes also, sometimes that happens. They have polyphagia and they lose weight. Right. So those are clear-cut features of hyperthyroidism. Then you have features of hypothyroidism. Hypothyroidism, remember, is much more insidious. Unless it's a full-blown hypothyroidism that has been there for a very long time, a patient is unlikely to actually come up and say that they have lethargy or things like that. Okay, so it's sometimes more difficult to diagnose hypothyroidism from your history than from your examination. Okay, then patients are sometimes clear-cut euthyroid, no symptoms at all. What you usually get though, when you take a few histories, are people who have a combination of these. Do you have sweating? Yes, I have sweating, right? Do you have constipation? Yes, I have constipation, right? Do you have lethargy? Yes, I feel lethargic, blah, blah. So you sometimes find a mixture of those. So one important thing when you are doing a short case is avoid leading questions. Don't ask them whether they feel lethargic or whether they feel anxious, right? Try to ask what are called paired questions. Do you have heat intolerance or do you have cold intolerance? Do you have diarrhea or do you have constipation? Pair questions together. Are you losing weight or are you gaining weight? Instead of asking, are you losing weight, right? When you give them two options, then sometimes patients give a more balanced response than when you're just asking leading questions. The other important thing is now you are racing against time in your short case. So don't try and ask questions that you are going to find answers to in your examination anyway, right? Are you sweating? Do you have tremors? Things like that. No point in asking because you are going to examine the patient and find answers to those things anyway. So thyroid status is one area that you need to focus on. Another area, like someone said, is features of malignancy. Now, malignancy is very uncommon in hyperthyroidism in this case, right? But we usually ask one or two features regarding that anyway. There are three typical features of malignancy, right? Malignancies are, sorry, this is wrong. Malignancies should be painful, okay? Not painless. So this is wrong. Malignancies should be painful, right? If a lump is painful, then we would probably think that the lump is malignant instead of a lump being painless, right? So that's an important thing to remember. Sorry about that. Right. So then recent rapid enlargement is a feature. And voice change again, because the recurrent laryngeal nerve can be infiltrated, is also a feature, right? So which thyroid cancers usually cause pain, voice change, and rapid enlargement? Anyone? Plastic cancers, okay, which only constitute less than 5% of thyroid cancers. That means that over 90% of thyroid cancers won't have any of these symptoms. So just because you don't find these symptoms, you can't say that the patient doesn't have a malignancy either, right? Okay, so we'll go to the next problem area that you need to think about. Right, again, like someone said, risk factors for malignancy, right? If there's a family history, not only of thyroid cancer, but breast, bowel, ovarian cancer, all that, you can sometimes have associated thyroid malignancy, right? And radiation is also a risk factor, right? Some people have risk factors for benign goiters, right? Family histories is important. Sometimes there is iodine deficiency, so you will need to ask about whether they used iodized salt, right? You might need to ask about the method of iodination of salt, because sometimes people iodize this, add the salt when the curry or whatever is still hot and bubbling on the pot, which means that you might denature the iodine, right? And also, traditionally, people ask about goitrogens, right? Things like cabbage, because these are famous questions from physiology and all that. People usually need to eat about 35 kilos of cabbage every month to get a goiter because of that, right? So that's not very common. Now, nowadays, of course, some people juice things like cabbage and make juices, right? And when they do that, sometimes they do consume quite a large amount every month if they keep drinking cabbage juice, right? With these juices, then of course it's possible, but commonly people don't ingest that amount of things. So in a short case, it's not really important to ask about all these things like Goitrogens, right? Then obviously you will need to ask about complications. Now, if a gland enlarges, right, you will have complications due to the gland itself, right? It can cause obstructive symptoms in two ways, any thyroid enlargement. One way is by pressing on the thyroid itself, on the trachea itself, right? Now, what is more likely to cause obstructive symptoms by pressing on the trachea? Is it a toxic goiter or is it a benign multinodular goiter? Okay, we can have a show of hands. Who thinks that? Okay, the question is, what is more likely to cause symptoms when obstructive symptoms by pushing on the trachea, right? Is it a benign multinodular goiter? Hands up, people who think it's a benign multinodular goiter. $35, $40, $42, $45, $46, $50, $56, $60. Okay, right. Hands down. People who think that it's a toxic goiter that can cause obstructive symptoms more likely. Seven. Okay. Yeah. So the majority is right. The issue is that the trachea is a hard cartilage, right? So just pressing on it doesn't cause difficulty in breathing or obstruction. You need to have pressure for a very long time to actually wear down the trachea, right? Make it something paper thin like this, right? Just make the trachea something really thin like this so that you get a condition which is called tracheomalacia, right? So a thyroid needs to press on the trachea for a long time and actually cause atrophy of the cartilage and thin it out and cause tracheomalacia in order for you to get airway obstruction due to that. Otherwise, just when you press on the thyroid or when the patient lies flat supine on the bed, the thyroid won't just fall back and make the trachea collapse, because the trachea has a semicircular rigid cartilage. So you need to have long-standing pressure. For that, it's usually a multinodular goiter, because a multinodular goiter takes years to actually grow slowly, right? You need to have 10 or 20 years of thyroxine TSH acting on a gland in order to get a multinodular goiter, right? And that's also why in this patient's differential diagnosis, a toxic multinodular goiter is less likely, because the patient is just 34 years and to develop a multinodular goiter itself would take about 20 years, right? Which means that if the patient is presenting with a toxic multinodular goiter, it certainly won't be a neck swelling for 8 weeks duration, which is now becoming toxic. A multinodular goiter is a very slow process, right? So that's an important thing to know. So the other complication, apart from obstruction, can be bleeding. You can get very vascular glands in hyperthyroidism sometimes, and they can bleed. Multinodular goiters also can sometimes bleed. But most of the complications that these patients have are cardiac complications, right? In Graves' disease, which I haven't mentioned separately here, in addition to the cardiac complications like arrhythmias, high output heart failure, and things like that, and all these complications like obstruction and all that, you might also get eye complications, which you need to look for. Right. Next, obviously, we have to talk about the patient's drug history, as people mentioned. Some people are on thyroid medications. This could be an iatrogenic thyrotoxicosis. Sometimes it's due to interactions. Okay, there are lots of drugs that cause very interesting interactions. For example, amiodarone can cause 3 different kinds of thyroid problems in patients. right? It can cause hypothyroidism, hyperthyroidism, right? It can even cause autoimmune thyroiditis. So there are various ways. It's an interesting drug to read about. Amiodarone is called amiodarone because it has iodine in it, right? The name itself implies that it has iodine, if you spell it right. Amiodarone, the iodine in amiodarone can cause various interesting effects. So read about that. There are some drugs that you need to know interactions about. Obviously, fitness for surgery, we will need to ask about the comorbidities and the MET score in patients, what is called the metabolic equivalence of task. If you don't know about it, read about it. That's an important thing to know. Lastly, right, you need to know what the patient's concerns are, right? Are there cosmetic concerns? The gland might be, if this is a toxic goiter, you might be able to manage this gland just with medications. But if the patient has cosmetic concerns, you might have to go for surgery in spite of the gland being amenable to medication. So there are lots of complications that you need to think about like that. And sometimes patients are worried that the gland might be malignant. So they want that sorted out also. So you just need to reassure them sometimes after investigating. Okay, right. So what I wanted to say is, if you just divide your history into these areas, find out the status, see whether there are any features of malignancy, ask for risk factors of malignancy, risk factors for benign goiter, any complications, ask about the drug history, fitness for surgery, patient concerns. If you break it into those areas, then within about 4 or 5 minutes, you have asked everything that you need as a overall safe history, right? So that's a easy way to kind of structure your history. In the same way, I want you to try and practice dividing other short case histories also into these problem areas. If I have a patient who has a breast lump, what are the areas that I want to ask about? If I have a patient with a hernia, what are the areas that I want to ask about? This will make your histories much more efficient, because you just focus on those areas and ask those. Right. So we will now move on to examination, right? For that, I'll just show you a short 6-minute video of the standard examination technique that's used. In some places, the technique that we use is a bit different from that. So I'll mention those differences also. During the thyroid examination, remember the website that I was going to show you. This is something that you would probably find useful for other examinations as well. It's you probably have seen the website. This is called geekymedics.com, and it's got quite a lot of information on clinical examination procedures in surgery, medicine, etc. Right. So, sorry, I think I didn't share with audio. Let's share this time with audio. If you cannot hear audio on this, please let me know.
Hello there, my name's Andrew. I'm one of the final year medical students. Could I confirm your name and age, please?
Hi, I'm Simon and I'm 24 years old.
Nice to meet you, Simon. Today I've been asked to examine the thyroid gland in your neck. Would that be okay?
That's fine.
This will just involve me generally inspecting, then I'll move in closer to the neck to have a closer look, and then have a feel of the neck as well. Is that all right?
Sure.
That's great.
So remember, introduction to a patient does not just mean saying that you are a final year medical student and you want to examine the patient, right? You also tell the patient what exactly you're going to do, that this will involve you taking some details, you coming close, you touching the patient's neck in this case, etc. Right? You don't just go, can I see, and drag the patient's pants off when it's a hernia, right? So explain to them what you want to do before you do it.
Are you comfortable where you are?
Yeah.
Fantastic. We'll start. Simon, if you could just bring your arms out in front of you like this and splay your fingers. Fantastic. I'm just going to lay a piece of paper on the hands. If you could turn your hands over for me. Finally, I'm going to feel your pulse. Thank you.
So are you happy with the feeling of the pulse, guys? Anyone?
Should at least listen it for 30 seconds at least.
Yeah, I agree. Why?
To identify any irregularities, arrhythmias.
Yeah, exactly. So in thyroid disease, you're not only looking for tachycardia and bounding pulses, you're also checking whether the patient has arrhythmias, commonly atrial fibrillation. Sometimes they have SVTs as well. So you want to check irregularity, which means that you have to palpate the pulse for at least 30 seconds, right? So you have to do it for a bit longer. Yeah, remember in any thyroid examination, we are usually attracted to features of hyperthyroidism. So when you look at the patient's face, you will immediately look for eye signs and things like that. But you will forget that coarse hair, right? Dry skin, loss of the lateral third of the eyebrow, etc. also needs to be seen and commented on, because in a general thyroid examination, you shouldn't just be looking at the patient's hyperthyroid features, although we are naturally drawn more to those.
I'm now going to look more closely at your eyes. If you could just pick a point on the wall behind me. And now I'm just going to look from the side. And I'll now look from behind. If you could just look slightly up for me, Simon. We're just going to do some movements of your eye now, Simon. So if you could just follow my finger, do let me know if you have any pain or double vision.
Note the distance between the two, the examiner and the participant. Right. So here he has asked the patient to keep the head perfectly still. If your patient isn't keeping the head perfectly still, you might have to keep the patient's head still for the patient, right? And that means that you'll have to stretch your other arm out and hold the patient's head. But if you do it this way, and if the patient listens to instructions, you can actually keep a meter's distance.
That's great.
Right. So at the extremes of the movement, especially if you have mild ophthalmoplegia, the examiner might not see a gaze palsy, but the patient would complain of double vision. So that's what you need to tell the patient anytime before you examine the eye movements.
Again, if you could keep your head still and follow my finger for me.
So what was he looking for there? Anyone?
Lid lag.
Yeah, that was lid lag. Okay, we'll go back. Yeah. That was looking for lid lag. So lid lag, remember, is not a sign of Graves' eye disease. Lid lag is something that you get anytime that a patient is hyperthyroid, regardless of the cause, because the upper 1/3 of the levator palpebrae superioris is supplied by sympathetic fibers. It's smooth muscle, right? So anytime that you have sympathetic overactivity, regardless of the cause of thyrotoxicosis, whether it's Graves or not, you will have lid lag and lid retraction. It's the other signs that are specific to Graves' disease.
Thank you. I'm just going to more closely inspect your neck now. If you just stay as you are. And if you could just take a sip of this water and hold it in your mouth. And swallow. Fantastic, Simon. If you could just stick your tongue out now. And I'm just going to feel your neck as well.
Right. So in this particular examination, the examiner is starting the examination from the very back, right? Just see what they're doing first now. Right. So he felt where the cricoid was, where the thyroid cartilage was, and found where the midline was, and then went down. When we are doing it here, the main difference that we have is that we start our examination from the front. That's because if a thyroid gland is very enlarged on one lobe, right, then the trachea gets shifted a lot. So where the left lobe and the right lobe actually is depends on where the trachea is. Otherwise, now you can see where he is palpating over here, right? If this patient had a large right lobe like that, right, and a small left lobe like that, and the patient's trachea had got shifted like that to the left side, okay, then what this examiner is feeling with both hands, right, is actually the right lobe. With this hand also he's feeling the right lobe, right? With this hand also he's feeling the right lobe. With this hand also he's feeling the right lobe. So he's not actually feeling the left lobe, and then the examination findings are wrong. So working out where the left lobe and the right lobe are actually depends on working out where the trachea is. That's why it's good if you start your palpation from the front, unlike in this case, and work out where the trachea is, walk down on the trachea, and depending on where the trachea is, then you can go to the back and start to palpate the two lobes. That way, if there's a massive deviation, you don't mistake the right lobe for the left lobe or vice versa.
If you could just stick your tongue out for me, Simon. That's great. And if you could just take a sip of the water for me. And swallow. I'm just going to feel the glands in your neck.
So again, at the exam, don't palpate lymph nodes on top of clothes, okay? You are not going to be able to feel anything.
Fantastic, thank you. I'm now going to feel your windpipe. It might be a little bit uncomfortable. I'm now going to tap on your
the
chest.
part that should have come at the front.
Finally, I'm going to listen. If you could just take a deep breath and hold your breath there.
Right. So this stethoscope only has a diaphragm. If you have a stethoscope with a diaphragm and a bell both, it might be useful for you to listen with the bell, right? Which area in the thyroid would you hear a bruit best? Anyone?
Right upper lobe.
Yeah, bilateral upper lobe, right? Not the lower lobe. So that if the thyroid gland was, sorry, if this patient's thyroid gland was probably something like this, right? Then maybe the stethoscope could be a little higher, somewhere over there. This is related to the way the two thyroid arteries come in. Okay, the inferior thyroid artery actually comes from down here and goes up like that, right? And it has a rather deep course over there, while the superior thyroid artery is coming off the external carotid artery and it turns down over here at this point, which means that this is much more accessible to your stethoscope and you can hear a bruit in the upper pole much better, right? So that's where you would place the bell of your stethoscope if you have stethoscope with both a diaphragm and a bell.
And breathe normally. Simon, I'd just like to finish with some special tests. So we're going to start with the reflexes in your arms. If you could just relax your arms on your lap like this with your palms facing to the ceiling.
So you don't need to do this if by this time you have established clear-cut hyperthyroidism. If you have established, if you suspect that the patient is hypothyroid, you might want to check the reflexes here. You might also want to check, yeah, we'll move on.
Fantastic. I'd just like to look at your shins, if you wouldn't mind rolling your trousers up for me. Sure. Fantastic. And finally, if you could stand up, but first I'd like you to cross your arms for me. And relax.
Right. Question. Apart from that, what are the other signs that you would see in the feet of a patient with thyroid disease? Can you just make a list and type out stuff? Signs in the legs of patients with thyroid disease. What would you look for? Pretibial myxedema. Okay, what else? What are the other signs that you would look for in the legs? Ankle edema. Okay, right. Why would a patient with thyroid disease get ankle edema? Good, slow relaxing reflexes. That's good. Ankle jerks. Yeah, non-pitting ankle edema in hypothyroidism. Good. Dermopathy. Good. What else? Yeah. Yeah, okay. Dry scaly skin. Yeah, good. You can even feel the dorsalis pedis pulse if you like and talk about those things also. Right. And remember, patients with hyperthyroidism have sweating in their palms and soles. Okay, so sweaty palms and sweaty soles are both seen. Sympathetics to the palms and soles cause sweating. So you sweat everywhere else when you exert yourself, but when people are anxious, people are stressed, and people are hyperthyroid, you get sweating in your palms and soles specifically, right? So hyperthyroidism, sweating from the palms and soles. Hypothyroidism, no moisture at all, so dry scaly skin. Good. Myopathies, that's another good one. Slow relaxing ankle jerks, myopathies, dry scaly skin, sweating, right? Sometimes pretibial myxedema, sometimes ankle edema, and remember, sometimes patients with hyperthyroidism are in heart failure, so you might even have pitting ankle edema, right? So there are lots of features to look for in the feet. Good. Okay, so I won't, I'll kind of stop the thyroid examination there. And we'll move on very briefly into our workup from this point onwards. So this is pretty straightforward in any thyroid, right? Regardless of the condition, we do a similar triple assessment through breast. Now in breast, one part of the triple assessment is clinical. But here, after the clinical assessment, there's a triad of investigations that you do. Always, we do the thyroid functions, the ultrasound scan, and the FNAs. So in any patient with any kind of thyroid disease, these three investigations you must mention, right? So in patients with hyperthyroidism, does anyone know what the danger of doing an FNAC is? Anyone?
Severe bleeding, sir.
Yeah, hyperthyroid glands are very vascular. So more than thyroid storm, we can cause bleeding, right? So that's the big danger in doing an FNAC in a patient with hyperthyroidism, right? The other question is, why do we usually do FNAC? It's when we are concerned about malignancy that we want a histological diagnosis, right? And malignancy is extremely rare in hyperthyroidism or in thyrotoxicosis. So you don't usually get malignancy and thyrotoxicosis together. It can happen, but it's very rare, which means that the role of FNAC is not really useful, one, in hyperthyroidism, and two, it can sometimes be dangerous also. So in patients with hyperthyroidism, in addition to the thyroid functions and the ultrasound scan, we do radionuclear uptake scans, right? So before talking about the results of radionuclear uptake scans, we need to talk a little bit about what differential diagnosis a patient with hyperthyroidism can have, right? So what are the causes for hyperthyroidism that you commonly encounter? Just type them in the chat. Common causes of hyperthyroidism. Toxic multinodular goiter. Okay. That is a multinodular goiter that has been there for a long time, has now gone mad, and is now not listening to TSH levels. It's secreting excess amounts of thyroxine. So this occurs in a multinodular goiter that has been there for a long time. Okay. Thyroiditis. Yeah. There, it's not secretion of thyroxine, it's destruction of the gland causing stored thyroxine to be released. So thyroiditis is another cause. Graves' disease, yes. Antibodies that are similar to TSH attacking the gland and tricking the gland into believing that this is TSH, and so it starts to grow and hypertrophy and become more vascular and also secrete thyroxine. Yeah. The last one is STN, right? Toxic adenoma, where the whole gland, the rest of the gland is fine, but one place is not listening to TSH. In a toxic multinodular goiter, lots of areas are not listening to TSH and just secreting thyroxine. In toxic adenoma, the rest of the gland is fine. It's very obedient, right? And it doesn't work at all because TSH levels are so low. TSH is screaming at the gland to not secrete thyroxine, but one particular area isn't listening. So those are the 4 common causes of thyrotoxicosis, right? And the other advantage of the radionuclide uptake scan is they give 4 completely different pictures in those 4 causes, right? So if you take the radionuclide uptake scan, right? So focus first on the normal thyroid gland over here, right? You have a relatively uniform uptake in the whole gland. Yeah, in Graves' disease, you have increased uptake in the whole gland because the gland is hungry for iodine or anything that looks like iodine, including technetium. In fact, the gland might actually be a little larger than normal also, right? Because the gland has grown and it has increased uptake uniformly, right? Then next, we have the hot nodule, right? As you can see, the rest of the gland, right, is actually suppressed when you compare it with the normal gland. That's because it's listening to the TSH, and in any of these causes, the TSH level is very low, right? TSH is telling the gland not to make any more thyroxine, but just one area isn't listening at all and is hot. And the rest of the gland has even less uptake than the normal gland, right? In toxic multinodular goiters, right, some areas are very active and some areas are actually cold and have no function at all, right? Sometimes these areas that are cold might actually be nodules, right? Those nodules are not filled with thyrocytes, but they're just filled with big pools of colloid in them, no cells at all, right? So these might actually be nodules, and these might also be nodules of interstitial tissue, right? And in thyroiditis, the gland is being destroyed. The patient is thyrotoxic, has tremors and things like that, but that's because of released thyroxine from the stores there. The gland itself is being destroyed, so it has less uptake when you compare it with a normal gland. So the 4 common causes of thyrotoxicosis have very nice, very different pictures to each other in a diagnostic radionucleotide scan. We might use a low dose of iodine for this, radioactive iodine, or we might use technetium-99, which is similar to iodine and gives us the same picture because glands think that technetium is actually iodine, so they take it up in exactly the same way that they take up iodine, right? So that brings us to the general workup, right? I am not going to go into detail on the management because this is something you will have to read a lot about, right? But just an overview of the structure of management of a patient with hyperthyroidism. Initially, most of these patients are controlled with medical management. All these patients will benefit from beta blockage if they have cardiovascular features. Anti-thyroid drugs will be effective in Graves' disease. They'll be effective in toxic multinodular goiter. They'll be effective in toxic adenomas, but they won't be effective in thyroiditis because it is not increased thyroxine production that is causing the symptoms. But beta blockage will be useful there. You will need to know a bit about the side effects and the contraindications of these drugs as well. Then, if it comes to Graves' disease, right, medical management alone will sometimes manage patients 1/3 of the time. Okay, 2/3 of the time, patients may not respond to medical management or relapse with medical management, so they might need to have some other option. Radioiodine therapy is sometimes given to these patients who don't respond to medical management. And some of these patients who have contraindications to radiotherapy have surgery, right? In toxic multinodular goiters, it is not something that is self-limiting like an autoimmune condition. So you will probably have to get rid of the gland. So we will usually have to operate on them. Toxic adenomas, again, we will have to either ablate the gland with radiotherapy or surgery. So medical management alone will work for Graves' disease. And in the short period of thyroxine release in autoimmune thyroiditis also, medical management is enough. If you are preparing, if you have to operate on these patients, hyperthyroid patients require specific management before surgery. You can't just operate on them like other patients with benign euthyroid multinodular goiters, because they might go into thyroid crisis. They might bleed a lot. Lots of complications are there. So you need to know the perioperative management of patients with hyperthyroidism. That can be asked in the exam, in the vivas, in the MCQs, anything. So that's a very important area to look for. And lastly, eye signs in Graves' disease are caused by antibodies. So even if you remove the thyroid completely, those will continue and sometimes worsen. And you will know how to manage, you will need to know how to manage Graves' eye disease also. So that's just a small overview of the overall management of any patient with hyperthyroidism. This area you will have to read about. And this is just a short overview of what people have found happens in Graves' disease, right? This study came from America a while ago, and it shows the outcome of patients with Graves' disease, right? According to US studies, if you give anti-thyroid medication for patients with Graves' disease for 18 months, half the time it succeeds completely and you don't need any further treatment, right? But once half the time it will fail. Then you can continue anti-thyroid medication again, or you can give them radioactive iodine, or you can do a total thyroidectomy in them. And all of these have various complications in each. Anti-thyroid medication going on for a long time has its own complications. Radioiodine has its own complications, right? Including a low risk of cancer also, right? Surgery also has its complications, right? Recurrent laryngeal nerve palsy, things like that. So you need to consider which of these is best in the 50% who don't succeed with just anti-thyroid medication, right? So that's a brief overview. We'll talk more in detail of the management by going through a set of 5 MCQs. I'll be giving you 2 minutes to answer each MCQ. They are as polls. So once the answers are given, we will discuss the MCQ over a couple of other minutes, right? So I'm starting the MCQ poll now with the first one, right? So this is a multiple choice question. You can click more than one answer. So just take 2 minutes from this point onwards and answer the question. And once you have answered the question, we'll discuss it over another couple of minutes. Sorry, I think my audio was off. Right. So we'll go to the first question again once you have finished this one, and I'll discuss it again. I think my audio was off. I'm very sorry about that. Okay, so I'm going to end this poll. Right. Let's go to the first one, and I'll just share the first question again with you, and we'll discuss that first. Right. Okay. So, which of the following signs and symptoms are results of thyrotoxicosis in Graves' disease? Right. So remember the issue here, the key here is what is thyrotoxicosis. Now remember, thyrotoxicosis is defined as a collection of signs and symptoms that occur due to increased circulating thyroid hormones, which means that what you are asked here is fine tremors at rest caused by increased circulating thyroxine hormones? Is lid lag caused by that? So on and so forth. So that's what you have to answer in this question. So fine tremors at rest, yes, it is caused by increased thyroxine in circulation because it causes increased sympathetic overactivity. Lid lag again, yes. Proptosis, no, because although proptosis does occur in Graves' disease, it's not a result of thyrotoxicosis, right? It's a result of the same antibodies that acted on the thyroid to stimulate it, acting on the soft tissue in the orbit and proliferating soft tissue in the orbit. Palpitations, yes, they do occur because of increased sympathetic activity. Raised diastolic blood pressure, no, because raised diastolic blood pressure occurs in hypothyroidism because of peripheral vasoconstriction. They have cold peripheries, right? Patients with hyperthyroidism have warm peripheries. They have bounding pulses because their diastolic pressure is low and their systolic pressure is high because the inotropic effect on the heart by the increased circulating sympathetic hormones cause increased cardiac output. So hyperthyroid patients have a high systolic pressure and a low diastolic pressure. So here response 3 and response 5 are wrong. Responses 1, 2 and 4 are correct. Now let's see how you responded. Right? You have, most of you have got the first response, the second response, and the fourth response correct. But several of you have marked the second and fifth responses as correct also, which is a problem. So that's how, as a batch, you have fared on that MCQ. Right. Now we will move on to the second MCQ, right? Which was, which of the following statements are true of thyrotoxicosis? Graves is the commonest cause worldwide, right? Then subclinical thyrotoxicosis may cause cardiovascular complications, right? So we'll go with the first one. Graves is indeed the commonest cause of thyrotoxicosis worldwide, right? In Sri Lanka, we are not currently sure whether it's toxic multinodular goiter or Graves. A decade ago, a generation ago, multinodular goiter with toxicity was much more common than Graves' disease. But now, multinodular goiters are becoming less and less common, and Graves is becoming more common. So our picture might change into the Western picture soon. But overall in the world, Graves' disease is the commonest cause. Second question. Subclinical thyrotoxicosis may cause cardiovascular complications. Yes, it does. Subclinical thyrotoxicosis is defined as thyrotoxicosis where the TSH level is low, but the T3 and T4 levels are normal. Now, if TSH is low, although T3 and T4 are normal in these patients, it is recommended that they may benefit from anti-thyroid medications until their TSH comes to normal, because what the agreement is that from patient to patient, the normal range of TSH might be T3, T4 might be different, but TSH is a more accurate representation of whether you are thyrotoxic or not than T3 and T4. So we go by that, and patients with even normal T3, T4 and low TSH levels are sometimes at a higher risk of cardiovascular complications like arrhythmias. So that's why it's treated. Thyroiditis may cause hyperthyroidism as well as hypothyroidism. That's true. In the initial phase, first 3 months or so of the disease, the gland is being destroyed, right? And later on, the gland is hypothyroid. The issue is with this word, hyperthyroidism. Hyperthyroidism is defined as increased thyroxine secreted by the gland. In thyroiditis, there is no hyperthyroidism actually. What we have is thyrotoxicosis, right? So hyperthyroidism is defined basically as thyroxine being secreted by the gland, which does not happen in thyroiditis. There is destruction of the gland and thyroxine is just released into the circulation. So it is actually false. Thyroid receptor antibody levels are essential in diagnosing Graves' disease. That is wrong, right? Graves' disease, if the patient has typical eye signs, is a clinical diagnosis. You absolutely don't have to do anything else. If your patient doesn't have typical eye signs and if you're not sure, the next thing that you do is the radionucleotide uptake scan, because that gives you a very clear idea of whether it's Graves' disease or one of the other 3 common causes. If there is any contraindication to radionucleotide scan, such as pregnancy, lactation, things like that, that's when you would go for thyroid receptor antibody levels to diagnose Graves' disease. So you don't usually need to do that. Hyperthermia in thyroid crisis is best treated with paracetamol. That's also wrong. In thyroid crisis, hyperthermia is not caused by a change in the hypothalamic set point causing muscles to contract. Now, in fevers, hypothalamic set point is changed by cytokines and things like that, and the patient starts to shiver, generates thermal energy, and becomes hot. So you change the set point again, and the patient cools down. And paracetamol changes the hypothalamic set point. Some fevers are generated independent of hypothalamic temperature changes, right? Typical examples are the hyperthermia you get in thyroid crisis, that is just by generalized increased metabolic activity everywhere in the body, not by hypothalamic changes. Rhabdomyolysis, malignant hyperthermia that you get due to some anesthetic drugs, all those also act in the same thing. No changes in the hypothalamus. So paracetamol is not effective in these cases. We just have to cool the patient with lukewarm water, what is called tepid sponging. That is the only thing that we can do in these cases. Sometimes muscle relaxants help to reduce muscle rigidity and shivering, but paracetamol doesn't. And that's why in your medical histories, you ask that very famous question, fever does not respond to paracetamol. These are the types of fevers that don't respond to paracetamol because they're independent of the hypothalamic set point. So these are your responses on that question. About half of you have said that Graves' disease is commonest worldwide. About half of you have said that subclinical thyrotoxicosis may cause cardiovascular complications. Again, a tip in answering questions, anytime that an MCQ response says may cause or may not cause, you are safe in answering it as true, because there's no never and there's no always in medicine. So if anything says may, you're pretty sure that that's a correct response. Thyroiditis may cause hyperthyroidism as well as hypothyroidism. That's an exception to where may cause is actually correct. That is because hyperthyroidism is defined as something different. And most of you have answered that as correct. Thyroid receptor antibodies are essential. About 1/3 of you have answered that as correct. Hyperthermia, I'm glad most of you have not marked that as correct. So you've understood the problem there. Good. Right. Now we'll move on to the third question. This is also a multiple choice question. You have 2 minutes starting now. Okay, we'll stop the poll now. And let's discuss that question. Surgical clinic for patients with thyroid disease. Right. Can you have lid lag and lid retraction without proptosis? Anyone? Yes or no, and why? Talk. Yeah, anyone? Unmute a mic and talk. Can you have lid lag and lid retraction without proptosis in a thyroid clinic?
Yes, sir. in cases in hypothyroidism other than Graves' disease?
Yeah, exactly. So lid lag and lid retraction are caused in any cause of hyperthyroidism or thyrotoxicosis, not only in Graves' disease, because it's because of sympathetic overactivity, right? So you're going to get patients like that without proptosis. Next one, proptosis without lid lag or lid retraction. Are you going to get that? Anyone?
Yes, sir, in untreated cases of Graves' disease.
Yeah. So by in treated cases, do you have proptosis?
Because it is not fully reversible.
No, because we don't treat the proptosis, no, right? Now, patients with Graves' disease, when you manage them medically, you're giving them anti-thyroid drugs. Anti-thyroid drugs don't change the antibody levels in the body. The antibodies are anyway circulating, and they are working on the eye and working on the thyroid. Although they are working on the thyroid, we have given anti-thyroid drugs, so there is no thyroxine secretion. So the patient becomes euthyroid. But the moment the patient becomes euthyroid, there is no lid lag or lid retraction anymore. But the antibodies are still working, so the eye signs can even progress, right? So eye signs are different to getting the gland under control. So you can have patients with proptosis without lid lag or lid retraction, right? Not because they have been cured and the eye signs persist. That also can happen, but the eye signs might actually be progressing. We don't treat the eye signs in the surgical clinic because, yeah, if you want to treat the eye as well, what do you give? Anyone?
Steroids.
Yeah, steroids. We have to give something that knocks the antibodies off, right? But we don't usually give it in Graves' disease because all we need usually to do is to control the sympathetic activity. And for that, reducing the thyroxine levels is enough. And if you give steroids to all these patients, they will respond beautifully, but they will develop all the side effects of steroids. That's why we don't usually give them, right? Then proptosis, lid lag, and lid retraction. This is easy now. Any patient with Graves' disease is going to have all these. Ophthalmoplegia, lid lag, and lid retraction. Anyone? Yes or no? Hmm?
Yes, sir.
Yeah, true. Why?
In Graves' disease.
Yeah, just like proptosis, ophthalmoplegia is also caused by the circulating antibody level. So all those things can be there. Right. So this is how you have responded. Most of you have got the first one correct, the third one correct, the fourth one correct, but the second one, about 25% of you have got correct, the rest haven't. Right. Now we are moving to single best answer, 2 questions, and you will get 1 minute each for SBAs. If you think that you have clicked on the wrong one, you can just click on the other one and it will change the response. Right, we have gone over 1 minute. I'll stop now. Right, so we are talking about a 35-year-old lady diagnosed with Graves' disease, tachycardia, a grade 2 goiter, and lid lag, but no proptosis. Which of the following is most appropriate? Right, so first one is control with carbimazole and propranolol, followed by total thyroidectomy. Right. Now that one is wrong because anyway in Graves' disease, our initial management is medical, right? 50% of the time, like we showed in that paper, we don't need to do anything more. And if medical management fails or there is relapse after continuing treatment for 18 months, our first option is radioiodine. We only give, only offer surgery to patients who have a contraindication to radioiodine. The contraindications to radioiodine are pregnancy or lactation, having a large gland, because that means you will need to have a very large dose of radiation going in. Okay, if the goiter is a grade 2 goiter, she is an unmarried lady, right? We assume she has no children, right? Then we don't need to go for a thyroidectomy. So that's wrong. Control with carbimazole, steroids and propranolol, followed by radioiodine therapy? No. Anyway, like we said, steroids are only given if the eye signs are very bad. She only has a lid lag. She doesn't have anything else. So you don't need steroids at all, right? And you don't need radioiodine therapy either here, as we discussed earlier. Control with carbimazole and Lugol's iodine, followed by total thyroidectomy, right? What is the use of Lugol's iodine? How does it work? Anyone? Yeah. So Lugol's iodine works using a very funny effect, which we call the Wolff-Chaikoff effect, right? For some reason that we don't fully understand, when you give a large dose of iodine to any gland, that shuts the gland off for a couple of weeks. You need to give the large dose of iodine for a short period. Now, obviously, when you give iodine to a gland with which is overactive, you would expect more thyroxine to be secreted. But for some reason, we don't really understand. When you give a large amount of iodine, very short, for a temporary period, the gland quietens down, right? And for a reason we don't know, it only works once. If you give iodine more or again, it's unlikely to work a second time. So we really don't know why that happens, but it's called the Wolff-Chaikoff effect, right? And we use this to our advantage when we are trying to operate on a patient who has hyperthyroidism, which is not responding to medical therapy. We would ideally like to control the patient with things like carbimazole, right? We do what we can, and propranolol also, but sometimes still the gland is very large, very vascular, and the patient is still symptomatic with tachycardia and things like that. In those cases, we give Lugol's iodine, right? You have to give it in a certain way. There's a certain number of days before the surgery that you have to give it. So you will have to read about those things there. I'm not going to mention that. But again here, that response is also wrong. Titration regime is safer than block and replace regime. So there are 3 ways in which you can give your anti-thyroid drugs to patients with hyperthyroidism. The first way is where you start with a slow dose and you increase, or you start with a high dose and you decrease, right? So if you start with a slow dose and you slowly increase it, depending on how much symptoms the patient has and how well they are responding, that is called the titration regime. titration is anumapane, the thing that you used to do with burette sets in chemistry practicals, right? Drop by drop until you get the correct concentration. So titration regime is that. The second one is the high dose regime, where you start with a very high dose and knock the gland off completely and then slowly reduce. The third method is where you give a very high dose, you continue a very high dose, and the patient becomes completely athyroid. They don't produce any thyroxine at all. And at that point, you give the patient thyroxine, just their maintenance dose of thyroxine. So you block and you replace. So out of them, for several reasons, the titration regime is considered to be safer. Block and replace was fashionable for a while, but people have realized that you are giving them higher doses of antithyroid drugs. And so adverse reactions of antithyroid drugs are more likely to occur if you give block and replace. And also, this is Sri Lanka, where we have to work with our normal clinic practice, which means that we prescribe these drugs to patients in the clinic and give them, and the patients also sometimes don't understand what they're taking. So imagine if a patient who has Graves' disease, right, and is very hyperthyroid, you start them on the block and replace regime. You prescribe high dose of carbimazole with thyroxine for them, right? Or you renew the prescription. They go to the OPD pharmacy and they don't have carbimazole, all they have is thyroxine. Carbimazole is out of stock. So that patient will be on thyroxine for a month and probably will not come the next time because they will have died of heart failure at home. So there are risks like that with block and replace regime in our environment also. So that's why titration is safer. Carbimazole should be continued at least 7 days after surgery? No, right? You need to continue the propranolol for at least 7 days after the surgery, because circulating thyroxine levels might cause sympathetic overactivity after thyroid surgery. Until the thyroxine levels in the blood come down to a reasonable amount, usually it takes around a week, you might have to continue with the beta blockers. But there's no point in giving carbimazole after a total thyroidectomy anyway, because carbimazole works only on the thyroid. So it won't work on anyone who doesn't have a thyroid. So these are your responses, right? Only about 23% of you have got that question correct. Right. Last question for today. Starting now, you have 1 minute. Okay, ending the poll. Right. So going back to this question, which of the following statements is most appropriate regarding surgery? Toxic multinodular goiter, failed medical management is the main indication, right? Okay, so that is a bit of a trick question. In toxic multinodular goiter, there is no such thing as failed medical management. In toxic multinodular goiter, it is not caused by an antibody process, which means that it does not self-limit, A toxic multinodular goiter, you can't continue antithyroid drugs for 18 months, stop it and expect them to be okay, right? Medical management by definition fails. So you don't go for long-term medical management in toxic multinodular goiters. You don't continue it for 18 months. You start the antithyroid medication. When the patient comes under control and is euthyroid, you have to get rid of the gland. Since these are multinodular goiters, they're usually large, which means that radioiodine can't be given because you need a large amount of radioiodine. Therefore, you have to operate on them, right? Second response. It is contraindicated in thyroid eye disease. No, for two reasons. Now, one is the eye disease is unrelated to this. So you have to get rid of the gland if you have to get rid of it. The second reason is, remember, this doesn't say thyroidectomy. It talks about surgery, right? And for thyroid eye disease also, various eye surgeries are done, right? Surgeries are done to increase the space inside the orbit. Surgeries are done to close the eyelid properly because sometimes they get chemosis and corneal irritation if the eyelid can't close because of the proptosis. So surgeries are done to correct all these things, right? Also remember, radiotherapy is given for thyroid eye disease also. That is different from your radioiodine that is given for thyroid glands. In thyroid eye disease, if the antibodies are causing a lot of activity in the orbit, sometimes orbit is irradiated with external beam radiation. So radiotherapy is also sometimes given for thyroid eye disease, and there are various surgeries also done for that. Surgery is the treatment of choice for a toxic nodule in pregnancy. Now, obviously, you can't treat thyrotoxicosis in pregnancy with radiotherapy. So the three options we have are anti-thyroid medication, radiotherapy, and surgery. Radiotherapy is out. Toxic nodules can be treated by radiotherapy. Like you saw in the uptake scan, the toxic nodule takes up a lot of iodine. So if the iodine has irradiation, it will specifically destroy just that toxic nodule. So that's fine, right? But you can't give it in pregnancy. Then you have anti-thyroid medications versus surgery. Yes, anti-thyroid medications do have some issues in pregnancy. Propylthiouracil is preferred over carbimazole, but still both those drugs are still safer than operating on a lady with hyperthyroidism in pregnancy. So we usually manage the pregnancy with anti-thyroid drugs, right? And remember, in toxic nodules, they are also not self-limiting conditions, right? Unlike Graves' disease, you can't give anti-thyroid drugs for 18 months and expect the toxic nodule to sort itself out. The moment you stop the anti-thyroid drugs, even 2, 3, 5 years later, the toxic nodule will start to reactivate. So you have to get rid of it either with radiotherapy or surgery. Usually, what we will do is we will wait until this patient has delivered the child and then go for the thyroidectomy. But the treatment of choice in pregnancy is anti-thyroid drugs. Thyroidectomy has a higher risk of bleeding in Graves' disease than in toxic adenoma. Yes, that is because although both these conditions can cause a thyroid storm, right, or a thyroid crisis because of surgery, right? In Graves' disease, the gland becomes much more vascular because the TSH-like hormone is stimulating the entire gland. So when you are doing a thyroidectomy for active Graves' disease or Graves' disease that is not under control, you might have to cross-match more than the standard 1 unit of blood that you do for a normal euthyroid thyroidectomy. And you might have to keep an ICU bed ready in all cases of surgery for thyrotoxicosis because the patient might go into a thyroid storm and you might need an ICU bed. So these are some of the things in preoperative preparation for surgery that I mentioned at the top. Lugol's iodine, these. Then thyroxine is commenced immediately after surgery to prevent sudden hypothyroidism. That's also wrong, because you don't give thyroxine immediately after surgery for the reason we mentioned earlier. You wait for a few days until the circulating thyroid hormones go down. Sometimes they go up when you handle the gland also. So these are your responses. The majority of you, or rather a larger amount of you, have got the correct answer here. But again, there is a significant number of you who have answered the other responses also. Right. So that's where we are. We've come to the end of our 2 hours, and we've also got completed what we wanted to. I'm going to stop screen sharing now. Let's see whether I can answer any of the questions that you have in the chat. Let's see. Are we performing for hypothyroid and euthyroid patients? Even for solitary nodules, can't we perform FNAC? No, you can perform for hypothyroid and euthyroid patients, and FNAC is needed because you are more concerned about malignancy than here. Here you are more concerned about the diagnosis of the cause, right, of hyperthyroidism. So no, you don't need an FNAC all the time, unless you suspect malignancy in a background of hyperthyroidism, which is rare. But in a patient who is euthyroid or hypothyroid, you're more worried about missing a malignant nodule, so you will be performing an FNAC. When the patient go for surgery, shouldn't he be euthyroid? Ideally, yes. But sometimes we have to operate for failed medical management. In those cases, unfortunately, we can't control the patient's thyroid status. We might be able to control the sympathetic activity with beta blockers. How does ophthalmoplegia occur without proptosis? No, it doesn't. Both those go together, right? Ophthalmoplegia actually occurs because the muscles of the orbit become weak while because of the substances deposited there stretching the muscles. So they occur together. Patient on thyroxine for hypothyroidism presents with acute coronary syndrome. How do we give them iodine? Because we've got to stop a high salt intake, right? So yeah, if the patient has a hypothyroidism, you don't treat them with iodine, because you don't know whether the hypothyroidism is actually due to iodine deficiency, or due to a pituitary problem, or due to a problem in the patient's gland, something like that. So you're not really sure whether this is iodine deficiency or not. So, and also to treat with iodine takes a long time. So patients with hypothyroidism, our treatment is thyroxine, not iodine. I'm glad you asked that. So that issue of salt intake doesn't become a problem. Right. Are there any other questions? You can either type them out or you can ask me. Hypothyroid status, does it complicate the surgery, as a hyperthyroid might go into toxic crisis? Yes, patients with hypothyroidism also can have lots of complications during surgery. They can have hypertension, and also they might not respond to things like bleeding. They might not be able to generate an appropriate tachycardia if they bleed and things like that. So their blood pressure control is also very problematic. Sometimes they go into things like myxedema coma if they are extremely hypothyroid. You can't wake them up from anesthesia. So for reasons like that, if it's not a urgent thing, we always control hypothyroid status regardless of whether they are being operated for the thyroid or whether it's something else. If it's a hernia, we would still correct the hypothyroid status before we operate on them, right? If hyperthyroid patient is made euthyroid with antithyroid drugs prior to the surgery, do we still need to wait a few days to start thyroxine after a total thyroidectomy? It's still safer because when you're mobilizing the gland, stored thyroxine can be released sometimes, right? What is better in pregnancy? Theoretically, propylthiouracil is better than carbimazole and methimazole, but those are all theoretical differences, right? There are plenty of instances where we use carbimazole also in pregnancy. Yeah, any other questions? You can unmute and ask, or you can type. Do toxic features disappear when gland increases in size? I'm not really sure how to in Graves' disease. No, not really, because if a gland is increasing in size, that usually means that the antibodies are still active, right? If the antibodies are still active and causing hypertrophy of the gland, then the patient will be toxic unless you have started to control with antithyroid drugs. Then the toxic features may disappear. After first trimester, can't we give carbimazole? We can. Like I said, it is given. We don't always get propylthiouracil. We sometimes give carbimazole even in first trimester, although it's not as safe. But it's certainly safer than surgery and radiation, which are the other two options. The third option is not treating the hyperthyroidism, and that is also unsafe. So you have four options. No treatment at all. Let the patient get complications of hyperthyroidism. Antithyroid drugs, surgery, radiation. Out of the four, antithyroid drugs, regardless of the trimester, are the safest option. Any other questions? Okay, so we started about 5 minutes late. So we are finishing about 5 minutes late. Thank you everyone for your questions and paying attention. And good night, everyone. And thanks to Vasantha and TRC and PeMSAA for taking the trouble to organize this. Vasantha especially was very helpful from yesterday, getting all the polls ready for the MCQ. So thank you everyone and good night.
Thank you, sir.
Good evening, everyone.
Thank you, sir.
Yes, sir.
Good evening, everyone. I would like to take this opportunity on behalf of all the students to convey our heartfelt gratitude on our to our very own Buddhika sir for such an amazing discussion on thyroid disorders. We know that it is a really busy week for you. In fact, as I recall that today evening also you were there making sure that everything is ready for this huge surgery on Saturday. So thank you so much, sir, for sacrificing your valuable time to deliver us this wonderful and comprehensive session. And in the meantime, I would like to acknowledge the efforts of PeMSAA for arranging these valuable sessions for the young buds who are blossoming in the near future. So thank you everyone for joining in today and wish you all a very good night.